Ma'am, you can start.
Yeah,
Thank you.
good. Yes. Uh, Good evening and a warm welcome to one and all to the Wednesday special thyroid clinics organized by the Indian Thyroid Society. So before we go to the session proper, we'll just go through the briefly about the achievements and the journey of the Indian Thyroid Society. Indian Thyroid Society was established and registered in 2003. It is a national body of healthcare professionals with special interest in thyroid disorders. Endocrinologists, endocrine surgeons, nuclear medicine physicians, general surgeons, and ENT surgeons are part of the Indian Thyroid Society. ITS is a member of the Asia Oceania Thyroid Association, that is IOTA. It has currently about 2,000 members. So in the executive committee, we have our founder president, Professor R.V. Jaikumar sir, and the current president, Dr. Shashank Joshi sir. Also in the executive committee, we have our past president, Professor Sarita Bajaj madam, secretary, Dr. Arun Menon sir, treasurer, Dr. Miniji ma'am. Vice President Dr. Himagirish K. Rao sir, Scientific Committee Coordinator Dr. Pramila Kalra Madam, Joint Secretary Dr. Sujay Ghosh sir are all members of the Executive Committee. Also Dr. P.K. Jabbar sir, Dr. Krishna Sheshadri sir, Dr. Mohammad Riyaz sir, Dr. Sushil Gupta sir are all members of the Executive Committee. Dr. Ashraf Chani sir, Dr. Mohammad Chenoy sir, Dr. Amaya Joshi sir are also in the Executive Committee. So, the aims of the Indian Thyroid Society is to organize academic activities for healthcare professionals, to promote public education and awareness about thyroid disorders, to encourage research in thyroidology, and the publication in the flagship journal that is Thyroid Research and Practice. The other aim is to have the state of the art publications and to award fellowship of the society and to encourage membership of the society as well. The ongoing academic activities which are undertaken by Indian Thyroid Society include the CMEs, updates, symposia, and conferences, the thyroid clinics, which were initially held weekly, fortnightly, and now being held monthly, have numerous topics like the journal club, the case conversations, the monologue, dialogue, panel discussion, meet the professor session, quiz, workshop, and CPCs. So, the programs which are undertaken by the Indian Thyroid Society include the Thyroid Awareness Week, which is celebrated between May 22nd to May 28th, the World Thyroid Day, which is celebrated on 25th of May, and the Thyroid Awareness Month annually is observed in January. The research activities undertaken by ITS includes the provision of annual grants for original research studies focused on thyroid and related disorders, preferably in the Indian context. And the research grants are available, which can be accessed through the website, that is the indianthyroidsociety.in. Regarding the flagship journal, that is the Thyroid Research and Practice, which is published twice a year in print and online, has a quick turnaround time with electronic copies available ahead of print. So the fellowship offered by the ITS include basically it is being awarded to the members with expertise and experience in the field of thyroidology, and it will be selected by an external expert panel, and the eligible members will be conferred the Fellow of Indian Thyroid Society. So the textbooks published by the ITS include the ITS textbook of thyroid disorders, editors of which are Professor Sarita Bajaj Madam and Rajesh Rajput sir. So the guidelines by the Indian Thyroid Society include the thyroid disorders in pregnancy, consensus statement of thyroid Indian Thyroid Society by Dr. Rajesh Rajput sir, Sarita Bajaj Madam, Sujay Ghosh sir, Pramila Kalra Madam, Arun Menon sir, Minima, which is published in the Thyroid Research and Practice 2023. So the upcoming guidelines include the management of subclinical hypothyroidism and thyroid nodule. The other published guidelines include the guidelines for the management of dyslipidemia and thyroid dysfunction, hypothyroidism and diabetes, and also the guidelines for the management of depression and thyroid dysfunction. So the Indian Thyroid Society, the website can be accessed through the Indian Thyroid Society.in, which has numerous contents like the links to guidelines, the access to ITS journals, records of all the academic events, and online membership portal as well. So the membership is basically awarded to all MCI registered modern medical practitioners in India. And there are two types of life memberships. One is the amount of which is rupees 2,950. The full-time life membership is awarded to the specialists in the field of endocrinology, endocrine surgery, and nuclear medicine, whereas associate life membership is for all the other registered medical practitioners. So the applications are invited online on the ITS websites, which can be accessed through the link that is the Indian Thyroid Society.in. So with that, we will now proceed to the session. So Indian Thyroid Society, the thyroid clinics, basically the webinar was initially conducted under the leadership of our distinguished Dr. Sarita Bajaj Madam and is now being held under the leadership of the four conveners, that is Dr. Shashank Joshi sir, who is the president of ITS, Dr. Pramila Kalra Madam, who is the scientific chair, Dr. Mini ma'am, who is the treasurer, and Dr. Anand Menon sir, who is the secretary of ITS. So, in today's session, we have our distinguished chairperson, Dr. Bashir Lavesa, who is the professor and head of endocrinology of Sher-e-Kashmir Institute of Medical Sciences, Srinagar. And to moderate the session, we have our distinguished moderator, Dr. Ravinder Goswami, sir, who is the professor of endocrinology at AIIMS, New Delhi. And we have two journal presentations. One is on Graves' disease, the other is on thyroid malignancy. And in between, we shall have a very interesting quiz by Dr. Kaushik Biswas, who is the senior consultant endocrinologist at Medica Super Speciality Hospital, Kolkata. And at the end of the session, Dr. Kaushik Biswas will be discussing the answers of the quiz, followed by the announcement of the quiz winners. So to proceed further, we shall now have the introduction of our esteemed chairperson, Dr. Bashir sir. So Dr. Bashir sir is the professor and head of the Department of Endocrinology of Sher-e-Kashmir Institute of Medical Sciences, Srinagar. Sir has numerous areas of interest and which include pituitary diabetes, hyperprolactinemia, and Sheehan syndrome. Sir has about 220 publications in national and international journals, including Nature Reviews, Clinical Endocrinology, Endocrine Practice, and DRCP, and Sir is the editorial board member of about a dozen national and international journals, including the IJEM. So over to Dr. Bashir sir to give the brief introduction about Dr. Ravinder Goswami sir, who is our distinguished moderator. Asmita, can you display the CV slide of Dr. Ravinder Goswami sir? So, Dr. Ravinder Goswami sir is presently the professor of the Department of Endocrinology at AIIMS, New Delhi. Sir has over 80 publications and numerous awards to his credit, like the Shanti Swarup Patnagar Award, the Shakuntala Amirchand Prize Award by the ICMR, the Fellow of the Indian Academy of Sciences at Bangalore, and the Fellow Indian National Science Academy of Allahabad. And also, Sir is the Fellow of the National Academy of Medical Sciences, New Delhi. So, with Madam's permission, shall we go ahead with the session, Madam? Asmita, I think Bashir sir has joined. So, can you display sir's CV?
Okay, ma'am.
Yeah. Good evening, Dr. Bashir, sir. We are just starting the session, sir. With your permission, can we go ahead, sir? Dr. Bashir, sir?
Good evening, Dr. Ganavi.
Yes,
Uh,
sir.
Dr. Goswami called me during daytime. He had some meeting. He said, I may be late by some time, so you go ahead. You should
Sure, sir.
start the
Sure.
process.
Yes, sir. I think, shall
So,
we start, sir?
yeah, please go ahead.
Yes, sir. So, to start the session with the introduction of our esteemed chairperson, Professor Bashir, sir. Sir is presently the professor and head of the Department of Endocrinology of Sher-e Kashmir Institute of Medical Sciences, Srinagar. Sir's areas of interest include the pituitary, diabetes, hyperprolactinemia, and Sheehan syndrome. And Sir has about 220 publications in national and international journals including the Nature Reviews, Clinical Endocrinology, Endocrine Practice, and DRCP. And Sir is the editorial board member of a dozen national and international journals, including the IJM. So, with your permission, sir, if we can proceed with the introduction of our presenters. Uh,
Okay.
yes, sir.
Okay. So we have selected two of our best and outgoing senior residents. So let me introduce. First will be Dr. Sailesh Bansiwal. He is the third year DM student, outgoing, and he will be appearing in examination very soon. Second is Dr. Ejaz. He also is a third year senior resident, DM senior resident. Both have appeared in theory, so they have to appear in practicals. So they have a good clinical exposure and they have done very good, in fact, I should say excellent work in their thesis work. Today they presented their thesis in the auditorium of Sher-e Kashmir Institute of Medical Sciences. So without wasting much time, I would request Dr. Sailesh to proceed ahead. I think his journal club would be uh, thionomides, administration of thionomide, carbimazole, methimazole in patients, or I should say, medical treatment of hyperthyroidism in children. We know that in adults, we are quite familiar with treatment of hyperthyroidism or Graves' disease. But also, we also know that it's not easy task to treat or to cure hyperthyroidism of Graves' disease in children. So we have to sweat around, and it is a very difficult task. So he will be presenting Journal Club on a very large multi-center study where they have seen what would be the effect of antithyroid drugs on Graves' disease and what are the remission rates and what is the success rate. So I would request Dr. Sailesh to go ahead.
Thank you, sir. So, good evening, everyone. Good evening to the respected chairperson, Professor Bashir Ahmed Lave, sir, and one and all present today. So, we will be discussing a topic today about the long-term outcomes of anti-thyroid drug treatment in the childhood onset Graves' disease. So, we know that Graves' disease is usually more common in the adolescent and the adult period, but it is less common in the children. But it is very severe in the children and it does not respond to the antithyroid drugs as it responds as it gives response in the adults. So this was a study which was conducted in Thailand, and it is over a period of 15 years. And this journal was published. This article was published in December 2022 in the Clinical Endocrinology Journal. So the plan of presentation will be introduction on the management of Graves' disease in children. Then we will have a brief review of the literature and then the journal club proper. So in children, hyperthyroidism is mostly caused by Graves' disease and is usually biochemically overt and clinically severe. In the childhood, Graves' disease accounts for around 5% of all the Graves' disease cases throughout the life, and it is 3.4 times more common in the girls as compared to the boys. But when seen before the age of 5 years, the ratio is a little bit lower, that is 1.4. So the presentation between the adults and the children are quite similar with a few separating points between them. So mostly the patient present with hoarseness of voice and poor scholastic performance in the childhood group. And other features in this group include accelerated growth and bone maturation. Rest of the clinical findings are similar between the childhood and the adults Graves' disease. Most pediatric patients with Graves' disease will not undergo spontaneous remission even after many years of antithyroid drug therapy and would require a definitive treatment. Remission rates in very large studies published before is only 30% in children. And this has been seen after the first course of antithyroid drug of about 2 years. So what are the risk factors for a lower chance of remission? And we should look into these before starting the antithyroid drugs. Like if a patient has enlarged goiter and if the TSI and the TRAB antibodies are very high, if he's pre-pubertal and have very high levels of free T4 and T3 levels. So there are a very low chances of remission in them, and we can have a definitive treatment in the initial period only. So because they will very rarely go into remission. So how we start these antithyroid drugs in children? We started at a dose of 0.5 mg per kg per day of methimazole or 0.75 mg per kg per day of carbimazole until the thyroid hormone levels falls toward a normal local laboratory normal range. And a lower starting dose of these antithyroid drugs can also be used in case of mild to moderate hyperthyroidism with the values values in the local laboratory reference range. But these are the values which have been given by the latest European Thyroid Association guidelines, which were published in 2022. PTU is generally not recommended in children. How we titrate the dose in these patients? As the patient become euthyroid or hypothyroid, then the doses can be reduced by approximately 25 to 50% if the patient has become euthyroid, and by 50% if the patient has become hypothyroid. And if the patient still remains hyperthyroid, then the ATD dose can be increased by approximately 25% in case of very severe hyperthyroidism. The dose is guided by the thyroid hormone concentrations within the first 4 to 6 months. And after these 4 to 6 months, we can follow by the TSH. But if the TSH again remains suppressed after that time, then it may reflect an elevated FT3 levels. And in that case, we have to increase the ATD dose again. So what does different guidelines tell about the treatment of this childhood Graves? The ATA recommends treatment with antithyroid drugs for around 1 to 2 years, and definitive treatment is advised if no remission occurs after that. But the European Thyroid Association has a different take on that. They recommend a longer duration of ATD treatment for at least 3 years and as long as 5 years or greater in patients who have a low likelihood of remission. And the Japan Thyroid Association has recommended a duration of 1.5 to 2 years, but they also say that longer term low dose antithyroid drug regimen up to 5 to 10 years may lead to remission in these patients. What are the indications for definitive treatment in these patients? So patients who develop antithyroid drug related side effects like neutropenia or severe liver dysfunction, and in patients who are unable to report the ATD side effects like the learning disability in the patient or the caretakers, and relapse and do not want further antithyroid drug therapy, and where there is a history of poor compliance in these patients. So we can go for a definitive treatment in them. So we will review the literature a bit. This was a study published in 2014 in Journal of Pediatric Endocrinology and Metabolism. So long-term outcomes of pediatric Graves' disease. 65 patients were seen in this study, and they have an onset of Graves before 18 years of age and a duration of more than 2 years since the diagnosis. So they have seen that all patients initially treated with antithyroid drugs, 53 patients were treated for more than 2 years. And among these outcomes, uh, uh, relapse after the initial remission was seen in 38. So from 63 or 38 patients have relapsed after the initial remission. And there was failure of remission in 8 patients, and long-term remission defined as a remission for more than 4 years was seen in 6 patients. So those needing definitive treatment had a higher mean free T4 and TRAb antibody levels. So they have concluded that long-term remission rates of pediatric onset Graves' disease with ATD are very low, especially with longer follow-up, and higher pre-treatment free T4 and high TRAb antibodies predict the need for an early definitive treatment. This was another study which showed positive impact of long-term antithyroid drug treatment on the outcomes of children with Graves' disease. And this was published in JCEM in 2012. It included 154 children of Graves' disease between 1997 to 2002. So around 5 years it has taken. And the intention to treat was that they have given 3 consecutive courses of carbimazole, each lasting 2 years. So at least 6 years of therapy they have given in this study. So the mean duration of follow-up was around 10.4 years, and they have seen an overall estimated remission rates 18 months after the withdrawal of antithyroid drug treatment increase with time, and were 20%, 37%, 45%, and 49% after 4, 6, 8, and 10 years of follow-up. So they have seen that as longer the therapy, the remission rate have increased over time. And they have also seen that the remission rate reaches a plateau after a certain time, that after 8 and 10 years, there will be no further remission, and whatever the remission is there, it is between these 5 to 10 years of follow-up. This was another study which showed predictors of autoimmune hyperthyroidism relapse in children after discontinuation of antithyroid drug treatment. This was also published in JCEM in 2008. This was a prospective multicenter cohort study of children, which included 154 children and a treatment duration of more than 2 years. And they were followed up for at least 2 years. So they have seen that overall estimated relapse rate of hyperthyroidism was 59% at first year and 68% at second year after the end of the treatment. So it was very high relapse seen in them. And a multivariate survival analysis showed that the risk of relapse was higher for patients of non-Caucasian origin, higher TRAb antibodies, higher free T4 levels, and it was conversely related to the relapse rate decreased with the increasing age. So younger age patients have a higher relapse, and the duration of the first course of the antithyroid drug treatment. This was a systemic review which was published in European Journal of Endocrinology in 2021. So methimazole-induced remission rates in pediatric Graves' disease. This was a systemic review. It included around 29 articles and 24 patient cohorts, including around 3,000 patients. And both the drugs were initially prescribed in around 93% of the patients, and they have seen a overall remission rate of 28.8% in these patients. So 30% is the range which most of the articles are giving for remission. And the pool remission rate, they have seen that 23, 31, 43, and 75%. Although the 75% was only a single study, and this was the only study which has shown such high remission rate in the children. Otherwise, all the study have showed a remission rate between 25 to 49%. So now the journal club proper. This was a long-term outcomes of antithyroid drug treatment in the childhood onset Graves' disease. It was a retrospective study, and Thai pediatric patient with Graves' disease who were diagnosed before the age of 18 years and initially were treated with antithyroid drugs. Patients were followed for more than 1 year, and the study duration was around 16 years from 2004 to 2020. And they have excluded the patients with neonatal Graves' disease or the Graves' disease associated with syndromes like Down's, Crouzon syndrome, etc. The diagnosis of Graves' disease was based on the clinical and biochemical hyperthyroidism and the presence of TRAb, anti-TPO, and anti-TG antibodies. All the patients were initially treated with methimazole or PTU because the study was from 2004. So initially they were treated with PTU also. After the year 2011, the PTO was changed to completely methimazole or carbimazole, and the doses were 0.2 to 0.8 milligram per kg per day for methimazole, maximum 30 mg per day, and 5 to 7 mg per kg per day for PTU. Antithyroid drug doses were titrated to achieve euthyroidism in these patients, and the antithyroid drugs were discontinued if the patient became either euthyroid with negative TRAb antibody or hypothyroid, despite having a very low dose of the antithyroid drugs, like 1.25 mg per day of methimazole or 12.5 mg per day of PTU. Clinical characteristics and grave disease related parameters were collected from all clinical visit until the study enrollment, and the cumulative incidence of first remission and proportion of first relapse were determined in these patients. Remission was defined as having clinical and biochemical euthyroidism without antithyroid drug treatment for at least 12 months. And relapse was defined as having clinical and biochemical hyperthyroidism after discontinuation of the antithyroid drugs. So this was the flow chart. This was the scheme of their article, their study. So initially there were 279 patients of Graves' disease, and they have excluded some of them with associated syndromes, and some of them needed definitive treatment initially only after the 4.7 months of treatment. So these included patients with serious adverse effects, and one was having papillary thyroid carcinoma. So finally, ATD continuation was done in 265 patients, and a minimum of 4.3 years of treatment were given in these patients. Among these, the patients who were poorly controlled, ATD was continued in them, like 95 patients, ATD was continued, and who had a little bit better control after 4.3 years, ATD discontinuation was done, and some of the patients with not controlled on these ATD, and they were given definitive treatment. Among the patients with ATD discontinuation, they have seen an initial relapse after soon after stopping the antithyroid drugs. The relapse was around in the 26 patients from 93, and the initial remission was seen in 67 patients. Among these patients, in the relapse cases, again the antithyroid drugs were started, and 4 patients then underwent remission after that. And 9 had to continue ATD, and definitive treatment was done in 13 patients. And in the remission group, again 25% patients went into relapse, and final remission was seen in 42 patients. So by this chart, we can see that from the relapse, these included around 51 patients, and total 30, and remission was seen after that in 14 patients. So total 37 patients had relapse from 93 total patients who had ATD discontinuation. So these were the results of the study. So in the ATD continuation group, in all the groups, the female have a higher ratio, and the median age was around between 10 to 11 years in all the groups, and majority were pubertal, but around 20 to 30% patients were prepubertal, and the other coexisting autoimmune disease was seen in 5 to 10% of the patients, and a family history of autoimmune disease was very important in them. Around 20 to 40% of the patients have a family history of autoimmune thyroid disease, and one of the most important factor which was related to the relapse was goiter size. So here we can see in the relapse group, the goiter size was around 4 centimeter, and whereas in the remission it was 3.5, and in the ATD continuation group was also 4, and a definitive treatment was 4.3, and this was statistically significant. Here we can see that 83% of the patients in the relapse group have a goiter size of more than 3.5 centimeter. Other factors which were related to the relapse were presence of TRAb antibody in a higher level, that 77% have positive TRAb body in the relapse group, and the levels were also higher in them, and the free T3 level was also statistically significantly higher in these patients who had relapse. And we can see here the duration of the antithyroid drug treatment were lower in these patients. So a longer duration of treatment has a positive result on causing the remission in these patients. So time until euthyroid achievement in this patient after ATD treatment was around 4.2 months, and the duration of ATD treatment minimum was mean was 4.3, with a range from 2.3 to 6.7 years, and the time since diagnosis to the enrollment was 7.1 years. So these are the three groups I have already discussed before in that flow chart. Out of the 256 patients, 265 patients, 56 patients went into remission with a remission rate of only 21%. And 37 out of the 93 patients had relapses with a relapse rate of 40%. So very high relapse and a very low remission was seen in this study. The cumulative remission rate of the first remission after ATD treatment increases with the duration of treatment. Here we can see that as the years of treatment increased, then the remission was also increased. But after a particular time, like after the 10 to 15 years, mainly in the 5 to 10 years, after these, the remission rate were almost stable. After 25, it has not increased much. And the maximum remission rate was achieved at a 5.3 years following the ATD therapy. Among the patients who experienced relapse, 51% occurred within the first year. So 51 and 75, almost 75%, 75% patients relapsed within the first 2 years of the treatment discontinuation. So among these 273 patients, 77% were treated with methimazole, and the remaining 23% were initially commenced on propylthiouracil. And the median doses were 0.4 and 4.4 mg per kg per day. And around 20 patients, 7% of these patients experience ATT-related side effects. And the most common side effects were cutaneous. But serious adverse effects, including vasculitis, hepatotoxicity, hematological problems, and severe hypersensitivity were also found in 12%, predominantly in the PTU-treated patients. So this is a diagram showing the side effects, and it was more in the propylthiouracil groups, 19%, but very less in the methimazole group. Only 4% of the patient had side effects. So what were the predictive factors associated with remission and relapse? Goiter size at the diagnosis of less than 3 centimeter has a good sign for remission. TRAb concentration of less than 10 international unit per liter, absence of Graves' ophthalmopathy, and MMI dose requirement at 1 year of less than 0.25 mg per kg. These are all good factors which we can initially see before starting the antithyroid drugs, and this have a good response. These factors have a good response with antithyroid drugs. Cox regression model demonstrated goiter size at diagnosis of 3.5 centimeter or greater was a predictive factor for relapse with a hazard ratio of 4.56. So MMI dose requirement during the course of the therapy during first to 9 years and 11 years of MMI treatment, patients in the remission group requires significantly less amount of MMI dose, that is 0.515 mg per kg per day, than in the patient with the definitive treatment, which requires almost double the dose. So in the discussion, this study found a lower remission rate of around 21% after 4.3 years of antithyroid drug treatment as compared to the previous studies with 24 to 49% remission rate. And only one study showed a 75% remission rate. The longer the follow-up period, the lesser will be the remission rate. The cumulative remission rate increased with the longer duration of the ATD treatment with a maximum remission at around 5 years. After that, it plateaus and there is no further remission. So after that, we can, if there is no remission, we can go for a definitive treatment. And only 7% of patients experience ATD-related effects, mainly in the PTU group, not much in the methimazole group. And this 50% of the relapse was within the first year, and around 73% within the 2 years. The factors I have already discussed. What are the strength of this study? This study included a large number of patients and has a long duration of follow-up, but it has also some limitations in the form of retrospective nature of the study and incomplete data due to the retrospective nature. And some of the facts were already known, which were proven in the results. Thank you.
Okay. Thank you, Dr. Sailesh. Dr. Ganvi, can we go ahead with the discussion if there are any questions or queries
Uh,
or comments?
so there are no questions in the chat box at present.
Okay. I just wanted, can I ask a question?
Yes, sir.
I just wanted from Dr. Sailesh. Sailesh, you said in one of the study, the only study which has shown a remission of 75%.
Yes, sir.
So did you go into those and what were their patient characteristics? How could it happen? Because most of the studies align with each other.
Yes,
But
sir.
one of the study was an outlier showing a remission of 75%.
25%.
Can you comment on that?
Sir, actually, the difference they have told that that can be due to the ethical factor or the study population in which they have taken, and the drug and the duration of treatment. And actually, initially, many studies have taken propylthiouracil as a drug, and the later studies have taken methimazole. So one of the factors they have told that methimazole may have a greater remission rate as compared to propylthiouracil. But this was only the first study, and they have not given much reasons why it was so higher. They have only told that because of the ethnic factors and the study design, these were the only factors they have told that because of which it had a higher remission rate.
Okay. Has this study something to do with the iodine level in the this thing, iodine deficiency or iodine sufficiency or no?
So this they have not commented on the iodine status of the population, sir. This study has also not commented, and that has also not commented.
I think
Dr.
possibly
Prasanna, I think wanted to say
person.
something.
Yes,
Dr.
yes,
Prasanna
yes,
wanted to say something.
If you look at the
yes, sir.
last 35 years, there is nothing new in this country. We are not going to English. Even in 35 years,
Audio is
there is
slightly weak.
Sir, your audio is little bit not very clear. If
can
you
you
can
hear
just
me?
be, yeah, now it is better, sir.
So 35 years, there is no environment. Though there are started with a 60 participation, even taking methodology. So these are all retrospective studies. Ultimately, this is to say what they are doing study. Total thyroid is nowhere better compared to methimazole or neomycin. So you will give 1 year, 2 years, or 3 years. Ultimately, in children, remission rate is very few, 20-25%, compared to other, where it may get 40%. So, what is it that you get from this message, 2 years or 3 years you take? Ultimately, it is the discriminated parents in children. All adults take it, and they get the definitive substance of all the criteria where they are surrounded. So going through all this, and in fact, even 35 years back, KCM publication was there, 900 patients, all of that 20 years two generation, video editing is safe, simple, easy to, then anti-thyroid drugs. Most of the patients, people because you don't give video editing to the after 6 years, we decide that we are given 3 years, it is surgery or radio, it is also good parent, unlike in an adult patient. This is what it is. My own take on after all this is, at this is not given any new information. Even beyond 3, 4, 5 years is useless. We relapse rate is going to be this big. That's what my take on after going through this data and all this.
Ganavi, I did not, in between, I listened something, but I could not get clearly. Did you listen and can you summarize 2, 3 points what Professor Prasanna Kumar said or no?
So yes, the audio was a bit not clear, but what sir was telling was that PTU, I think, is not much beneficial as compared to methimazole or carbimazole. And also, from what I could hear, what sir said was that anti-thyroid drugs in children, there is a the relapse rate is quite high. So the most like the choice of treatment would be to go for radioiodine ablation.
Right, right. Thank you. So, we have any other comment or any other question before we go to the next journal club? So,
Yeah.
if Yes, Dr. Call.
There is no
No.
question. We can move ahead. Yeah.
Okay. So we can start the second journal club. It is from Dr. Ejaz Qadir. He
Sir,
will be
We have,
talking.
yeah.
sir,
Yeah.
yes, sir.
Ma'am is coming.
Uh,
There's a quick, yeah. Ganvi, you can take it. Yeah.
Yes, ma'am. Yes, ma'am. Thank you, sir, for a very interesting discussion. And also, I would like to thank Dr. Shailesh as well. You presented really well about all the different studies on childhood Graves' disease. So the next session is the quiz, the most interesting part of the thyroid clinics. So I now request Dr. Bashir sir to introduce Dr. Kaushik Biswas sir, who is the quiz master for today's session.
Generally, there is a question in this
I think,
question. You might have missed it.
okay.
So it is radioactive iodine up to the age of 10 years in children. Again, I tell the hamburger in 88 has published data of 900 children, followed 20 years, absolutely safe, no increased cancer, hardship, or even dietary dose. Children born to those who have received them. So that way, we can say that at the age of 10 years, radioactive iodine is safe. At least I have followed up many children for 30 years. Now they are married, having children, none of them have problem. So the final answer is radioactive iodine is as safe as children. Actually, guidelines are above 6 years. You can go up to 8 or 10 as safe as it in the others, even if you follow it. That's my answer. Suggestion.
Okay. So should we go ahead with the introduction of the for the quiz or no,
Madam, can we go
Dr.
ahead,
Ganvi?
ma'am?
Yeah. We
Yes,
can go
please.
ahead.
Yes, please.
Okay, Dr. Kaushik, he is very interested, and most of the time is you would see him preparing an endocrine quiz. It is not an easy job. I mean, once you are given the job, so you have to do a lot of hard work. So he is the senior consultant endocrinologist at Medica Super Specialty Hospital, Kolkata. So he has around 31 publications, and his areas of interest are diabetes, thyroid, obesity, and technocrinology. I would sometimes look to have a CME like this on technocrinology, so which as an old person would like to listen from him. And he has a young thyroidologist. He's a young thyroidologist. He has got the award of young thyroidologist in India, which is given by Indian Thyroid Society. So I would request Dr. Kaushik to please go ahead with the quiz.
Thank you, sir. Good evening, everyone. Today, I think they will share the slides. Yeah. So these are the quiz participation rules. Will you?
Yes,
Yeah,
sir, I will be
Dr.
reading that.
Ganvi will just detail about it and then you can go ahead. Yeah.
Yes, sir. To participate in the quiz, having a Zoom app on your mobile device or laptop is essential. You're requested to use a laptop for the ease of experience. The quiz will run for about 10 minutes. There'll be first two dummy questions followed by the actual quiz, and the quiz master will display the case or description of the quiz by screen sharing a PowerPoint file. And the participants should use the polls option to participate in the quiz, and all 10 questions will be available when the poll is launched. And answer for all the questions is to be submitted at the end of 10 minutes. To read the case or description, you can close the polls using the X button and again use the polls option to answer the respective question. So with that, I request Dr. Kaushik sir to present the questions.
So first
Go with the
two
dummy
dummy
quiz.
questions. Right? Yeah.
Hello.
Yeah,
Can
yeah,
I
yeah.
go with the
Smita.
dummy quiz?
Yeah. Asmita, you're not able to display it.
Yeah, I've started.
Yeah. So the first dummy question is, in which city is Taj Mahal located? Option A, Chennai. Option B, Mumbai. Option C, Agra. Option D, Bangalore. The second one is how many oceans are there? Option A, 8, option B, 5, option C, 6, and option C, 7. So with that, I request Dr. Kaushik sir to take over.
Okay, so yeah. So demonstration is over, I think. And now the actual time, we'll enter the actual session of quiz. Will you display the first question, please?
Sir, you
Ashmita?
are sharing your PPT. I'll launch the poll once you sharing the PPT.
Should I?
Yes, sir.
Okay. Sorry, give me a moment. I think, is it visible?
Yes, sir, it's visible.
Yes,
Okay.
yes.
So the first question is, which is the major thyroid hormone binding protein in cerebrospinal fluid? A, albumin; B, transthyretin; C, thyrospondin; D, thyroglobulin. Kalra ma'am, please respond where should I stop, okay? Please.
After 10 seconds, you can move to the second question.
Every 10 seconds, you move to the second question. Next question means.
I think it's over.
Yeah.
The second question is, multiple endocrine neoplasia type 4 is associated with genetic mutations in which gene? A, RATE; B, BARD; C, CDKN1B; and D, EPCAM or EPCAM. Which one of them is mutated?
Third question.
So we'll move ahead.
Yes, sir.
Thank you. The third question is, which is the drug with similar efficacy and superior reduction of proptosis when compared to IV methylprednisolone for active Graves-associated orbiopathy? A, triptomimab; B, rituximab; C, sunitinib; and D, pembrolizumab.
What's the next question?
Thank you. So fourth question is, a 27-year-old male presents to the OPD with history of neck swelling. On evaluation, he was found to have thyroid nodule. Which is the next test that you will order in this patient? USG thyroid, FNAC thyroid nodule, TSH, anti-TP antibody. 27-year-old male presenting with thyroid nodule.
The next.
Fifth question is, which among the following may precipitate thyroid toxic storm or thyroid storm? A, paracetamol overdose; B, aspirin overdose; C, morphine overdose; and D, tricyclic antidepressants.
Next question.
A 34-year-old female with Graves' disease is on antithyroid drugs. Now she is 34 weeks pregnant. Which of the following is unlikely to be a fetal or neonatal outcome? Unlikely. A. Fetal hypothyroidism. B. Neonatal hyperthyroidism. C. Neonatal central hypothyroidism. And D. Neonatal central hyperthyroidism.
Next question.
Look at the two pictures. Diagnose the syndrome associated with the congenital hypothyroidism. A. Pendred syndrome. B. Bamforth-Lejeune syndrome. C. Cocker-Debris-Semeligne syndrome. And D. Down syndrome. Look at the pictures very closely. It's very obvious.
Next question.
So thyroglossal cyst is lined by which of the following epithelium? A. Pseudostratified ciliated columnar epithelium. B. Stratified columnar epithelium. Squamous cells or cuboid cells? Straightforward question. So next question. So look at the pictures. Look at the pictures. There are 4 pictures. One is a duct. Another, you can see the umbilical artery, the picture of the person of interest today, and the thyroid gland, the virtual thyroid gland, and connect them by naming the person or naming the which can connect all these 4 pictures. A. Dr. Thomas Wharton. B. Dr. Emil Theodor Cocker. C. Dr. Haraku Hashimoto. And D. Dr. Carl Besdo.
Next question, sir.
This is a difficult one. Identify the variant of papillary thyroid carcinoma usually seen in the background of familial FAP, that is familial adenomatous polyposis coli. A tall cell variant. B. columnar cell variant. C. follicular variant. D. cubriform morular variant. Look in that areas. Here. So time's up, I think.
Thank you, sir. They were definitely thought-provoking questions. So the answers for all these questions will be discussed after the second session, and then quiz winners will also be announced after the discussion. So to move on, I request now Dr. Bashir sir to introduce Dr. Ajas Kadir, who will be presenting the second journal.
So, Ajaz is the third year DM senior resident at Sher Kashmir Institute of Medical Sciences. So, he will be presenting a journal club on low risk thyroid carcinoma. I mean, there have been some studies which say that we should just go for surgery, and he will discuss the role of radioactive iodine. Should we really give radioactive iodine in these patients, or we should sort of not go for radioactive iodine? So this is a very big study which was published in New England Journal of Medicine. So let us see, Dr. Ejaz, you have, I think your time is slightly less as compared to what Sailesh had. So you please go ahead.
Respected chairperson, and good evening to everyone. I am Dr. Ejaz Kadir from Department of Endocrinology, going to present journal club on thyroidectomy without radioiodine in patients with low risk thyroid cancer. My moderator is Professor Ramendra Goswami, Department of Endocrinology, AIIMS New Delhi. This basically journal was published in New England Journal of Medicine last year, and it is this journal was this study was done in basically in France, and it lasted for almost 5 years. It started in March 2013 and ended in April 2017. So first of all, I will start with brief introduction about thyroid malignancy. How risk stratification in thyroid cancer? Basically, when we have suspicious nodule in a patient, then we go with the diagnosis. After that, after doing TSS, we go with the diagnosis. Then if we have suspicious, as per BISTA classification, if we have four or five, then we go with the surgery. And depending upon which type of surgery we will go, whether it is total thyroidectomy or whether it is a lobectomy, it depends upon the size as well as nodal status, as well as whether it is unilateral or other node is also involved. So after that is very important post-operative management. How do we manage post-operative these patients? Whether we should go with the adjuvant therapy or we should just follow these patients. For post-operative, we have two risk stratification. One which was given by AGCC in 8th edition, and another which was given by AGCC. They only give risk of death. But another risk stratification is American Thyroid Association risk, which was published in 2015. It divides basically into three risks. One is low risk and intermediate risk and high risk. After that, we go with response to therapy and dynamic risk assessment. In the response to therapy, we say whether there's excellent response or biochemical incomplete or structural incomplete response or indeterminate. Then we 6 monthly go with the dynamic risk assessment, because if initially we have low risk, maybe in future it will go into intermediate risk or it will go into high risk. That depends upon basically thyroglobulin levels, ultrasound of the neck, nodal status. That will go simultaneously. It's called dynamic risk assessment. So what is the need for risk stratification? Basically, risk stratification gives us risk of structural or biochemical disease recurrence, likelihood of going into remission following initial therapy, and importance of dynamic risk assessment. This is a ATA risk stratification, which was published in 2015. First is low risk. Among them, we have PTC with all of the following: no local or distant metastasis, all macroscopic tumor has been resected, no tumor invasion of locoregional tissues or structures, no vascular invasion. tumor does not have aggressive histology like Tolls, Hobner variant, or columnar cell carcinoma. If radioactive iodine is given, there are no radioactive iodine avid metastatic foci outside the thyroid on the first post-treatment whole body radioactive iodine scan. Clinical, if N0 or 5 or less pathologic N1 micrometastasis, the size should be less than 0.2 centimeter, or intrathyroidal encapsulated follicular varieta PTC, or intrathyroidal papillary microcarcinoma unifocal or multifocal inoculum BRAF mutation, intrathyroidal well-differentiated follicular thyroid cancer with no capsular invasion or no or minimal less than 4 foci of vascular invasion. And then we have AT intermediate risk. I will be more focusing on the low risk, and then we have AT high risk. So how do we manage these patients if we have low risk? How do we manage these patients as per ATA guidelines? They say that evaluation post-operative disease status we have to do with means of thyroglobulin ultrasound, and after that radioactive iodine herniate ablation not routinely recommended. They are not clear about whether we should give radio ablation, remnant ablation or not. They are not clear because when these patients are undergo thyroidectomy, if we have another scenario, if we go lobectomy in low risk thyroid carcinoma, suppose we have size of less than 1 centimeter, and if it is unifocal, then we have to go lobectomy. For this, American Thyroid Association is very clear about it. We do not have to go with the radioiodine ablation, radioactive iodine remnant ablation. So this is what is basically advantage of going with the radioiodine ablation in these patients? One advantage is to destroy benign residual thyroid tissue, then we have to ablate. Another advantage is to destroy suspected but not identified remaining disease. And third is to perform, as I mentioned, a highly sensitive post-treatment whole body scan few days after radioiodine administration. These are the three advantages why we usually go with radioiodine ablation after surgery. So for low risk thyroid cancer, we have why is there a doubt about whether we should go with the radioiodine ablation or not? This doubt was basically this is when they have published these guys, they have told that the role of radioactive iodine adjuvant therapy in ATA low risk differential thyroid carcinoma should be clarified in the future following completion of RCT, such as iodine or not trial for low or intermediate risk patients. This was because there were no RCTs present at that time. So they say that it may be confusion may be cleared in the future with the help of randomized controlled trials. So this is what will it help in low risk DTC radioiodine ablation will help or not? Basically, there is only persistent disease after surgery. There is only 1 to 3%. So if we subject these patients with radioiodine ablation, risk is only 1 to 3% after that, even if we do not subject these patients to iodine ablation. So let us see what literature says about this. What are the studies? What will they help or not? This was published in JCM. Impact of low risk differential thyroid cancer with radioiodine. It was a retrospective multicenter registry. 1,298 DTC patients categorized as being in the ATA low risk were followed for a median of 10.3 years, and there was no significant effect of radioiodine ablation adjuvant therapy overall or disease-free survival. This was also a retrospective study. Another was also updated systematic review. It was also published in 2008, which says that upon carefully examining the best existing long-term observational evidence, the authors could not confirm the significant consistent benefit of renal radioiodine ablation in decreasing cause-specific mortality or recurrence in early stage. Then we had another systematic review which was published in JCM in 2015. They have reviewed the data which was published since 2008, and they have also found that there is no evidence of renal radioiodine ablation benefit in recurrence prevention for low-risk patients. What I have mentioned, these studies, they were all retrospective studies. So they were not prospective studies. So that was the reason American Thyroid Association told at that time that future studies should be done possible to give answer to this question whether we should go with the radioiodine ablation in low risk or not. So this was a study. This is the journal which I am going to present today. This was published in New England Journal of Medicine last year. This has been started. This study has been started for that purpose. This is thyroidectomy without radioiodine in patients with low risk thyroid cancer. This was open label randomized phase 3 trial using a non-inferiority comparison design, which in which one group was given radioiodine ablation, and in other group there was not given radioiodine ablation, and they were followed for 3 years, and after 3 years they assessed them to see whether there occurred event or not. This was funded by French National Cancer Institute, and it was started in March 2013, and up to April 2017 this study lasted. So what was the inclusion criteria in this study? Basically, all adult patients more than 18 years of age with differentiated thyroid carcinoma, that's papillary, follicular, or oncocytic. This was multifocal PT1A tumor that is size was less than 1 centimeter, because in unifocal it is clearly mentioned there is no role of radioactive iodine. So they have taken multifocal PT1A TNM staging, or PT1B more than 1 centimeter or less than 2 centimeter. They have not taken size from 2 to 4 because these patients have higher chance of recurrence. So they have taken size should be less than 2 centimeter and multifocal PT1A. And nodal status was, there was clinically no node involved, or nodal status could be assessed only during the session, and absence of extrathyroidal extension. Plus, these patients underwent total thyroidectomy with or without dissection of the cervical lymph nodes 2 to 5 months before starting the study, and plus post-operative neck ultrasound without detection of suspicious abnormality. These patients were subjected after surgery ultrasound. There was no detection of suspicious abnormality. Exclusion criteria were patient with aggressive histotype, that is poorly differentiated tall cell or cylindrical diffuse sclerosing variant, patient with known distant metastasis, abnormal post-neck ultrasound of lateral lymph node compartments, patients with another malignancy not in remission for at least 2 years. So what were the primary endpoints? First was to assess non-inferiority of no radioiodine group versus radioiodine group with respect to percentage of patients without a functional structure or biological event during 3 years after randomization. So what was functional event described? It was described as absence of radioiodine uptake outside the thyroid bed on post-ablation whole body scan or on SPECT. Structural event was described as abnormal findings on ultrasound of the neck, and biological event was described as elevated level of thyroglobulin or anti-thyroglobulin antibodies. Secondary endpoints were quality of life, anxiety, fear of recurrence, and dysfunction of lacrimal and salivary glands. These were assessed by means of some skills they have used. That is, one, they have used a short form 36 questionnaire in which there were 36 questions, and they asked these patients about those questions, and they accordingly assessed them. Another was Spielberg state trait inventory. There was also questionnaire which they used. So the second endpoint is were assessed by means of those scales which they used. This was the how did they do it? First of all, there was randomization. Then they ablated one group, and another group was asked to follow up. In first group, which was ablated, they give intramuscular injection of recombinant TSH, was 0.9 milligram was given, IM was given on 2 consecutive days, followed by a hospitalization for ablation with radioiodine or SPECT. Then 10 months, both groups were followed. One was which was radioiodine, in which stimulated thyroglobulin level was measured and neck ultrasound was done. Another group which was not ablated 10 months after randomization, in which non-stimulated thyroglobulin measurement was done under thyroxine treatment and neck ultrasound. Then second visit was 2 years after randomization, thyroglobulin measurement was done, and third year was another randomization. Third year in both groups, similar thyroglobulin level was measured. and neck ultrasound was done at that time. This was after third year, after 3 years. So this was how was event? How did they describe event? This was ablated for ablated group. 10 months stimulated thyroglobulin level. When thyroglobulin level was more than 5 nanogram per ml, it was called an event. And another definition was between 1 and 5 nanogram per ml and remaining more than 1 nanogram per ml on measurements performed with an interval of time of at least 6 months. And this was at 10 months. Then after that, it was after 2 years and 3 years. Thyroglobulin level it was non-stimulated during follow-up more than 5 nanogram per ml or between 1 and 5 nanogram per ml, remaining more than 1 nanogram between the measurements performed at an interval of 6 months. For follow-up group, which was not ablated, thyroglobulin level, which was measured at 10th month, event was described as more than 5 nanogram per ml. And for another decision was if thyroglobulin level was non-split thyroglobulin level was 2 and 5 nanogram per ml, and remaining more than 2 nanogram per ml on two measurements performed with an interval of time of at least 6 months. This was also definition of event detection of thyroglobulin antibodies more than upper limit of normal or increase in thyroglobulin antibody titer more than 50% between measurements performed 6 months apart was also considered to be composed criteria. So how was excellent response described at 10 months? It was described as normal findings on neck ultrasound, that is thyroglobulin level less than 1 nanogram per ml after administration of recommended stimulated TSH or during thyroid hormone treatment. It was for no radioiodine group and absence of increased level of thyroglobulin antibodies. Excellent response at 3 years was described as normal findings on ultrasound, neck ultrasound, the thyroglobulin level less than 0.2 nanogram per ml for radioiodine group, or thyroglobulin level less than 1 nanogram per ml for no radioiodine group during levothyroxine treatment, and absence of increased level of thyroglobulin antibodies. After that, they did molecular analysis on these patients to see what happened to these patients, because these are very important. Now, molecular analysis is very important in thyroid carcinoma. For this, they took nested case control study was done, in which cases they took patients with an event in which event occurred, and controls they took patients without an event. So nested case control study they made. Each case was paired with two controls based on the following criteria: TNM staging, whether it is PD1A or PT1B, histological results, sex, age group, neck dissection, treatment group, whether one has received radioiodine or no radioiodine. This was basically an enrollment criteria. 776 patients under randomization and 389 were assigned to receive post-operative iodine, and 26 were excluded while lost to follow-up, died, unrelated thyroid cancer, and they did not give the withdrawal consent. And finally, 363 patients were included in the per protocol analysis. This was 387 patients were assigned to follow-up only without post-operative radioiodine. 20 were excluded. One was included in error. 19 could not be evaluated 3 years. 11 were lost follow-up. 2 died unrelated to thyroid cancer, and 6 withdrew consent. Finally, 367 patients were included in the per protocol analysis. This was final analysis here. These were their clinical features. These were their features. One was radioiodine and no radioiodine. And it, almost they were similar in age as well as sex as well as other features in which randomization was done. You can see female sex almost in one group it was 82%, and another 83%. Histological type, TNM staging, multifocality, almost it was similar between the two groups. What were the results? Results were that no radioiodine group, 95.6% no event occurred. In radioiodine group, 95.9% no event occurred. There was only difference of 0.3%, which met non-inferiority cutoff, non-use of radioiodine. So primary event no radioiodine group, 16 of the 367 patients, that is 4.4%. In the radioiodine group, it was only 4.1%. There was not much difference between the two groups as far as primary event was concerned. So these were the where how did primary event occurs if we take radioiodine group or no radioiodine group. So no primary in which occurrence was in 15%. In no radioiodine, it was 16%. So foci was radioiodine uptake or abnormal lymph node in 2 patients, where also thyroglobulin level in 6 patients, and thyroglobulin level during thyroxine treatment and thyroglobulin antibodies was present in 2, whereas in no radioiodine it was 5, and increase in titer was present 2 patients. This was finally last. This was in no in radioiodine only. No event occurred in 95.6%. In no radioiodine it was 95.0%. So they met the non-inferiority criteria. So subsequent treatment, surgery, radioiodine administration are both no radioiodine group only in 4 patients and radioiodine group in 10 patients. Other patients without additional treatment, external response was almost similar in both groups, and adverse events occurred in 30 patients, non-related to treatment, and no thyroid-related deaths. Secondary endpoint, which I mentioned, they used various scales. So quality of life, anxiety, distress, and fear of recurrence, similar scores in 2 groups. Salivary or lacrimal dysfunction, similar frequency in 2 groups, and lacrimal discomfort more common radioiodine group at 2 months after randomization. It was because they used radioiodine ablation. So what was the result of molecular analysis, which they submitted to 90 patients? So BRAF mutation was present in 50 patients, RAS mutation was present in 14 patients, and no genetic abnormality was present in 17 patients. The third mutation was not present in any patient. So frequency of BRAF mutations was not materially different between case and control. So there was no difference between the 2 groups. These were the prognostic factors associated with a primary event in 730 patients, which could be evaluated during 3 years. So among them, I want to highlight 1-2 points among these. The one was this size. Primary event occurred more in patients that the size was less than 14 mm. This could be sometimes surprising because size was less, but the reason they have given because in these patients tumor was multifocal, so the primary event occurs more in these patients. And in another second, those patients who had high thyroglobulin level more than 1 nanogram, primary events was also more frequent. So the important from this that those patients whose thyroglobulin levels are high, then we have to monitor those patients closely to look for any recurrence of the disease. So discussion of this was less than 5% of the patient in 2 group had events as concorded with the definition of low risk thyroid cancer. This trial showed that the risk of events was not higher in absence of post-operative administration of radioiodine. Patients in this trial were representative of patients with PT or 1 thyroid tumor ranging 20 mmR less, or category that constitutes 50 to 70% all thyroid cancer, and 50-70% of those with nodal status of N0 or NX. So genomic abnormality in trial patients similar to those listed in thyroid data set of Cancer Genomic Atlas with BRAF mutation present in 50% of the patients. However, in retrospective study, they found that presence of BRAF mutation is V600E is a poor outcome. But in this study, they have found that it appears that in patients with low risk disease, presence of BRAF mutation would not be an indication for radioiodine administration. Strength of the study was it was prospective study, head-to-head trial between 2 groups, which lasts for 3 years. But the limitation of these results were that results should be confirmed with longer follow-up, because we have seen that most of the recurrence that occur up to 5 years of age. So this study should last for 5 years. But they have mentioned that this is ongoing, that it will last for 5 years, because most of the recurrence occur within 5 years. So in this trial, a tumor less than 14 mm was predicted. Possibly they have given the reason that it could be because of multifocality of the tumor and no mention of the ethnicity of the population. They have not factors like gender, age. They have not compared these factors. So finally, this was a non-inferior trial if we do radioiodine ablation versus no radioiodine ablation. Thank you.
Thank you, Dr. Ejaz. I think he has made it the study crisp and clear. I think if we have a low risk early thyroid cancer, even if it is multifocal, but is a low risk, so we need not to go for radioactive iodine. So if there are any questions he would like to respond, Dr. Ganvi, Dr. Kalra, are there any questions?
I think only one question in the question box, that is for the previous one, but I think it was already answered. How safe is it to give radioiodine ablation in less than 10 years of age? That was the one question which had come up.
Shailesh, you want to?
So, ma'am, usually in less than 10 years of age, it is not recommended due to the high risk of malignancy associated with, in this age group. After 10 years, we can safely give radioiodine in children also.
Okay.
And from with the new papers, they have also mentioned that less than 5 years of age is a more appropriate age where we can take that, and 5 to 10 we can give a trial of radioiodine.
Even 5 to 10 they have written, but most of us prefer to do it little bit later, by after 10. Like very young children, we mostly avoid because we don't have very clear-cut information. But yes, there are studies, yes.
Any other question is there? Anybody wants to make a comment or?
I think there's another question. Precautions may be difficult in young children. Vikram has asked. I'm not sure what is being asked here.
So, Ejaz, would you like to?
Contact with the family.
Yes, I think yes, that is a common sense thing.
Yeah, absolutely.
But that is a secondary thing. But scientifically, we should not give the age group of less than 5 years. Yes. But this issue is there. Yes, definitely this issue is there. I mean, the child may not remain isolated, and we would not like to keep the child isolated. It's very difficult.
So those are practical issues.
Yeah.
The main thing is like you were saying, the science behind it is important. And I think the age is becoming younger and younger. So between 5 to 10, maybe, yes, it will be approved later. We don't know. But above 10, like Salish said, I think that we have a clear-cut answer there. So I think Azaz has very clearly highlighted the strength as well as the limitations of the study. Because I think the limitations are the standard ones, more patients, longer follow-up. Then the size of the tumor also you've mentioned very clearly. Then the age, the ethnicity, and the sex. So otherwise, I think this is an interesting data that you have presented.
2 more questions have come up. How many millicurie of I-131 is used for whole body scan? And the other, what to substitute if the child develops neutropenia with antithyroid drugs?
That's Nikhil Sanjeev. Yeah, please.
Ejaz,
Yes,
Ejaz, you want to take the first
yes,
one?
3 to 5 whole body scan. We have only 3 to 5 millicurie. We have to give for whole body scan. Is only 3 to 5 millicurie we can give for whole body scan if we want to do. Otherwise, for therapeutic purpose, there are different Suppose it is intermediate risk, then we have to 30 millicurie, high risk is 100 millicurie, but whole body risk is 3 to 5 millicurie. It is only 3 to 5 millicurie minimal dose.
Shailesh, you want to have comment on this and then go to the second question?
For
3
the
to 5
diagnosis,
is okay, but we can give maybe less than that. It could be even 1 millicurie.
Sir,
Is it?
textbooks mentions 3 to 5 millicuries.
Okay. Shailesh,
about the second
second question.
Uh, actually, if a child develops neutropenia, it is an idiosyncratic reaction. So during that time, we have to stop that, and either we should go for a definitive treatment with radioiodine, or we should go for surgery if needed. Because in these patients, we cannot continue the antithyroid drugs.
I know we read a lot about lithium. I'm just curious as to any experience. I don't know.
Lithium.
Yeah.
So,
I don't have any
okay.
experience.
So, Shailesh, you want to comment on your experience? We give sometimes lithium. We sometimes we are forced to give lithium. So, suppose somebody has a liver disease or somebody
most of the times
liver
there,
disease, I remember.
Yeah,
But
most of the
otherwise,
times we have
this is
used
not
in
a
those scenarios. And
Yes.
also when these patients who have developed the neutropenia post the antithyroid drugs and they are in sick state, we cannot immediately ablate them. To buy time, we give them and then later on ablate them. So that's another indication where we use, and also obviously hepatic dysfunction, especially toxic, very toxic graves where we cannot immediately ablate. And there's a liver dysfunction also coexisting. So there, lithium we use.
How frequently do you monitor the lithium levels in that case?
Most of the times we would ablate these patients within 2 to 3 months of their becoming better. So we actually don't monitor much of the levels. We just monitor the the thyroid functions, and we mostly ablate them within a span of 3 months. So that's why we mostly don't monitor. But if we have to continue longer, then we definitely have to monitor.
Okay. Because I think the margin, I'm not sure
It's
if
very
like
narrow.
toxin, it's very narrow if I remember
Yeah.
right. So one has
Basically,
to.
lithium, I agree with Dr. Kalra. Lithium, we cannot give, we don't give for a long time. So I think by 3 months, most of the times we have decided
Yeah.
कि इसको कहाँ भेजना है. So it's a short term.
It's just to
That is why
buy
we don't.
time for
That is why we
the
don't monitor. Yes,
prevention.
just by
Yeah.
the time.
There's one more question from Ankit Chabra. Risk of malignancy in children after radioactive iodine is more theoretical. It's more of a comment, I think, but still recommended is above 10 years. I think it's just sort of dittoing what we have said, perhaps.
Yes. Above 10 years is the recommendation. Below that, it's only like we have some data, but we cannot recommend. One more question is there.
Okay. Of course, we're here.
The answer for how much I-131 is 1 to 3 that we already discussed, that we can give a very low dose also. We give 2 actually. 2 or 1, that is also okay. So that they have written, that's a comment. And because the higher the dose, that is 3 to 5, the stunning effect is more. Hence, nuclear medicine physicians do not prefer to give more than 3 for a diagnostic scan before ablation. So if you are planning to ablate, and most of the times in these patients, if we have to ablate, so they don't give more than that. So actually we use a very low dose, 1 to 2 is what we normally prefer. We don't go beyond that. So that is 1 millicurie is also enough. 2 is most of the times okay. And one more question has come. Severe reaction to antithyroid medication first trimester. What option we have for treatment? First trimester of pregnancy. Yeah.
So in the first trimester, we can either shift it to propylthiouracil at a lower dose to see we can change it and see if there is progression of that reaction or not. Otherwise, in the second trimester, we can go for maybe surgery because radioiodine is absolutely contraindicated.
No, but the question is very categorical.
Yeah.
First trimester only.
First trimester.
It's first trimester.
Yeah.
And
It
if
is
the
a
group
very,
is
very
the same, it's
difficult
all
scenario.
thionamides, PTU, not numericazole, I'm saying carbimazole or whatever we give, right? The group is actually thionamides, isn't it?
The same group,
Right.
but
Yeah, I'm just wondering if switching, irrespective of whatever is recommended. Have you ever, I don't know if this has happened. I really have not had an experience of any problem in the first trimester. Of course, it's possible. Of course, it's definitely possible. But I think I've been lucky in that regard. So can we switch, if the patient is on PTU, start on the carbimazole?
Because we recently had a patient who had a neutropenia just before when she was pregnant, actually, and she came and she actually had a neutropenia. We didn't know that time that she's pregnant. She was on antithyroid, so we had to stop. We just monitored her. Thankfully, by the time she reached the second trimester, she went into remission. So we were okay with that. We were reviewing few possibilities. Obviously, if she's very toxic, then we have to think about definitive therapy in the second trimester. But most of the times, they will go into remission. Most
But
of the times.
what was the TSH TRAb?
Ma'am,
I
her
mean,
TS, her
TRAb.
TRAb is high. Her TRAb was high. She was she was confirmed Graves 6 months before we had started her on treatment.
Oh, okay.
She was
So she was
confirmed
not a
Graves
DPT,
patient
na,
before
kahin se.
pregnancy. Yeah, she was confirmed Graves. But thankfully, she went into remission by the second trimester. Her free T4 was normal, so we were good with it. Otherwise, we were reviewing the options, what could be done. We were thinking also of cholestyramine. But again, the safety of cholestyramine during pregnancy is not well established. So they only say that if in case you have to use it, the benefits should outweigh the risk. So that's the only option we were thinking of in case she becomes very toxic for the first trimester, because we can't go for surgeries immediately. We can't do much. Antithyroid, because she had neutropenia, there was no question of giving any antithyroid drug. So those are dicey scenarios. So that time we reviewed if cholestyramine can be tried, but still it is not approved as such. But only thing they say, benefits outweigh the risk, you can think about it. That's how it is.
But before pregnancy, before she conceived, was an RA, radioactive iodine uptake was not done. It was only TRAb.
That was done, ma'am. That was done
It
6
was
months
all
back.
confirmed. So there's
It
no
was all
doubt about the
confirmed.
Graves.
No, ma'am. She was a known Graves follow-up patient.
Oh.
And following up, and then she came with neutropenia. That time, incidentally, she was pregnant also. So that is how it came into picture. But she was started on treatment some time back. We didn't she just came with neutropenia. We didn't think that time, but then we checked the pregnancy test and it was positive.
Yeah, I know we are talking about neutropenia here, but routinely, I don't know. I don't know. I don't frequently order, CBC to see what the counts are like, or is there any recommendation that you need to follow it unless the patient has complaints, or is it a routine practice?
Ma'am, the guidelines actually don't clearly mention that you have to definitely do. Only they say that if you have those symptoms like fever more than 2 days, mouth ulcers, or the typical things, but we always write all those things, swallowing difficulty and fever more than 2 days, and these routine things we write. We had a patient who came with loose motions. She didn't come with any of these, and she actually went to the surgeon. Thankfully, the surgeon did the CBC, and it was severe agranulocytopenia. And immediately we took her into the ICU and we could save her. We have lost 1 or 2 patients because they didn't come back to us. So it can be a very serious scenario. But if we see the guidelines, they don't recommend routine doing CBC for every patient, and neither on follow-up unless the patient has these symptoms. But this is like the only thing they say is educate the patient. That is what we always do. Education is the most important thing.
I think that is tough in the Indian scenario. But
That
I
is the
think
problem, ma'am.
maybe
Yeah.
ITS, the Indian Thyroid Society, should come up with some recommendation.
Absolutely. I think in our country, it is very important because the patient we lost, unfortunately, never came back to us. And she went to many doctors, but the only thing, she didn't come to endocrinology. She had her paper, but unfortunate for her that it was not seen, and she went to some other place and it was not taken care of. So that was really unfortunate. So that's why we have to be very, very cautious, I think. Because in Indian scenario, whatever the international guidelines, though we do all the education, but we don't have a follow-up system, like the records are online for all patients, like that thing doesn't happen in our country. And many a time the patients don't show their records. So I think a high index of suspicion is important. Repeated counseling of the patient at every visit is the key. I think that is the best we can do.
We have another question. I don't have the answer to that. What is the dose and formulation of lithium safe to start? The neutropenia, hepatotoxicity. So what is the dose that is being given?
We
Any
start
resident wants to
Shailesh,
take
you have?
this?
Yeah,
start with
anybody?
we can
Sailesh or Azaz?
we can start with 300
Can
mg OD, ma'am, and then we can look for the levels of thyroid hormone.
Would
Mostly
you?
they require BD. 300
BD,
BD is
mentioned.
what we give most of the times, and they do well. OD you can start, you can see and follow up. But most of the times our patients require at least 300 BD. But as we discussed, it is for a short duration, just to buy the time. It's not going to continue long. So we don't worry about the lithium toxicity much, because we are not going to continue this treatment for a long time. It's just the time patient gets better and we plan for a definitive therapy, mostly radioiodine, and then we take care of the things.
I think we've had a good discussion here. I don't see any more questions. Does anybody else see? There's a comment again. We have achieved euthyroidism from SKIMS itself in 2 to 3 patients on lithium at SKIMS who had major adverse effects to ATDs.
Yeah.
So obviously it's a referral center. So
Yeah.
you see more patients or more,
Yeah.
problems or,
True.
yeah. So Ganvi, I think we can go back to Dr. Kaushik Shwas.
Yes, ma'am. I request Dr. Kaushik sir to answer the questions which were presented before.
Yeah, to give us the answers to the quiz. He's not going to answer the questions.
Yes, ma'am. Yeah.
Sure, ma'am.
To discuss the answers.
Yeah. Is it visible?
Yes, but
Yes,
yeah, that's
yes.
fine. That's nice.
Yeah, thank you, ma'am. So the first question was major thyroid hormone binding protein in CSF. The answer is transthyretin. We know that transthyretin is a protein which is secreted by the liver and the choroid plexus. So the answer is B, transthyretin. MEN type 4 is associated with genetic mutation of CDKN1B, which produces protein that is P27, which is a tumor suppressor. It causes cell arrest at G1. So this is the correct answer is C. Which is the drug with similar efficacy and superior reduction in proptosis in comparison to methylprednisolone? It is the triptomimab, that is the anti-IGF-1 receptor antibody, which is very effective but costly. The fourth question, what should I do after having a patient with thyroid nodule? First investigation. The answer is TSH, because if TSH is low, I should go for thyroid scan.
Yeah.
And if TSH is high or normal, then depending on the situation, we should do a USG thyroid, and we should look for T-RAD score. And fifth question is, which among the following may precipitate thyrotoxic storm? Then answer is aspirin. Aspirin leads to there is a release of thyroid hormone from the thyroid hormone binding globulin and from the albumin as well. So there is free thyroid hormone excess, and that can lead to thyrotoxic storm. Now, female patient, 34 years old, Graves, and which of the following are unlikely event? It is the neonatal central hyperthyroidism, which is very, we know that fetal hypothyroidism can occur because of the thianomides we use in pregnancy, and neonatal hyperthyroidism because of the placental passage of IgG immunoglobulin. Central hypothyroidism neonatal had also been reported in some cases with maternal Graves, but neonatal central hyperthyroidism is almost impossible mechanistically in mother with Graves. This is, of course, a case of Bamforth-Lejeune syndrome. The child is having this spiky hair. We can see the cleft palate. And this syndrome is very rare. Only 8 to 10 cases throughout the world or families have been reported. And they are associated with congenital hypothyroidism and sometimes bifid glottis, and some cranial and facial dysmorphism can also be found. Thyroglossal cyst is lined by pseudostratified ciliated columnar epithelium because it is developed from this thyroglossal duct, which is also lined by the same epithelium, not the cuboid cells. Now, the answer for this question is Dr. Thomas Wharton, and this is the possible picture of Dr. Thomas Wharton, who has described the submandibular duct, the green line, and this is the Wharton's jelly in the umbilical cord, and he named the thyroid. So this is the connection. And finally, the answer is cribriform morular variant of papillary thyroid carcinoma, which is rare but very specific finding in patients with FAP. You can see the morule formation in the background of cribriform distribution of cells. Overall prognosis in this type of papillary thyroid carcinoma is good. So now I'll share the another 5 sets of questions. Just give me a moment.
Those were the ones that were asked before the
True, ma'am.
questions. Yeah.
True. So I think this was the teaser question. Which among the following drug does not produce suppression of TSH? Dopamine, dexamethasone, octreotide, and aspirin. I have just explained that aspirin actually increases the level of free T4. And we know that dopamine, dexamethasone, and octreotide, especially during acute administration, reduces TSH levels. Second question was, which among the following is the most or the commonest thyroid function abnormality in patients with acute psychosis? High T4, low T3, low TSH, and high TSH. Although we know that different types of thyroid, hypothalamic pituitary thyroid axis abnormality can be seen in patients with acute psychosis. But however, the so-called hyperthyroxinemia or elevation of total T4 is most common abnormality found with acute psychosis. Third question was, pralsetinib is a new drug used in the management of which conditions? Papillary thyroid carcinoma, medullary thyroid carcinoma, amyloidosis of thyroid, and metastatic follicular carcinoma. It is medullary thyroid carcinoma. We know that pralsetinib is a specific rate inhibitor, which is associated with a better adverse event profile than the commonly used multikinase inhibitors like vandatinib or cabozantinib in medullary thyroid carcinoma. Drug which is what is the drug of choice for Hashimoto encephalopathy was the fourth question. Levothyroxine, corticosteroid, liothyronine, and antipsychotics. Answer is very straight. The most of the cases respond very well with corticosteroids. Some other form of immunomodulation, such as plasma exchange and IVIG, have also been reported to improve these conditions. Treatment option for methimazole-induced hepatotoxicity is a difficult question. Lithium, intravascular glutathione, oral zinc, and ethanol. I have found only anecdotal answer for this. It is intravenous glutathione. I found only one report where intravascular glutathione was associated with improvement with methimazole-induced hepatotoxicity. But frankly, I have never used it in my clinical practice. Thank you.
Thank you, sir.
Wouldn't just stopping methimazole work?
Yes, madam. That should be the first step.
Yeah. So you think you're saying it's idiosyncratic, of course.
Yes, ma'am.
But if it doesn't work, how long would you wait, for example? I mean, it's hepatotoxicity. You're obviously suspecting.
Usually, madam, usually stopping if the situation is mild to moderate, stopping methimazole will suffice in most of the cases. But sometimes we use steroids like IV methylprednisolone, which can help us in rest of the cases. But very rarely, I found only only one article about uses of glutathione. That question was meant to, to
Just
discriminate.
to create the awareness, yes, that we have this option is available. Very nice. Very nice question. Thank you. Thank you.
Thank you, sir, for giving us the answers for all the questions. I now request the IT team to display the quiz winners so sir can announce the winners for both the sets of questions. So you're muted, sir.
So
some
these
questions in the chat, not chat box, but somewhere else I saw some more questions.
Okay, so winner of today's winners are Dr. Fayaz Ahmed Abdul Rahim, Dr. Meena Viswal, Dr. Ramesh Kumar Singh. I think this is for the 10 sets of questions, the final questions, correct?
No, this was
Not
7th.
yesterday.
Today's
Yesterday,
8th.
yes.
Oh,
This is
so
7th November.
brilliant. Okay.
Today is the 8th.
Okay. So this is the today's answer.
Yes, sir.
Okay, so Dr. Lakshmi, yes, I know you. You are always the winner. And Dr. Reshma Hem and Dr. Nikhil Sanjeev. Congratulations to all of you.
Congratulations to all of you, really. Like you said, Lakshmi is one of the regulars. Like I think Bharti Kola used to be earlier. Pramila?
Yeah, ma'am. She is now exam going.
Yeah.
One more question in the chat box is there from Dr. Rajeshwari. I want to know opinion about acceptance of diagnosis of Hashimoto's encephalopathy from ITS.
I think it's a well-established entity.
Yeah.
I don't think there's anything to doubt about it. And I think Kaushik has highlighted the management as well.
Yeah.
There's absolutely no doubt. And it's a well-known and not a recent entity. I think it's almost a decade, more than that, perhaps. We are aware of that.
Only thing is the diagnosis, the high index of suspicion is more important because sometimes the clinical picture may be very, very difficult to recognize that it is Hashimoto's because they may be having many things which may not fit into a particular diagnosis and many things might have to be excluded before we make a diagnosis. And some of the EEG changes may be very typical in some of the patients, especially in older patients. Many of them we have seen, but the best thing is the response to steroids is very good. So if the diagnosis is correct and we give steroids, we'll get an immediate response. That is one of the other ways, because sometimes we do think of a diagnosis of Hashimoto's, we give steroids and we don't see the response, then we should definitely think about other possibilities. Because many times I feel that it is being overdiagnosed also, many times. And but the only thing is the response to steroid is so good that in case the patient has not responded, I think we definitely need to revise our diagnosis.
See, even for otherwise, say if a patient has raised intracranial tension, the first treatment is steroids.
Yeah, ma'am.
So again, that would make it a bit tough, because patient is already on steroids. You're not sure about the diagnosis. You're just, like you're saying, it's a diagnosis of exclusion.
Right. Only thing is the other evaluation would have already have been done before we do it, and imaging and all that would have been done. So those things would have been seen, fundus and imaging. All these things are done, and the encephalopathy panel and everything, autoimmune encephalitis panel. Then only we think about this when we are not thinking in terms of, and most of the time they'll also must have undergone lumbar puncture also. So all these things would have been done, and then we come into the picture. So I think by that time we would have little bit clarity that the other possibilities are very, very less. But as you rightly said, sometimes they are already on steroids for some of the other indications. Then if they are still having, then we have to definitely think that if it is something else, because then it is little bit unlikely. The response to steroids is actually very good. Then the patients confirmed Hashimoto's, we have seen very good response to steroids.
So over to you, Ganvi.
Yes, ma'am. Thank you, sir, for announcing the winner. So with Dr. Bashir sir's permission, we shall now conclude the session. I request Dr. Sarita Bajaj madam and Dr. Pramila Kalra madam to give the concluding remarks.
And Pramila?
Yeah, ma'am. Okay. So I thank everyone. And the only thing is that, like, we know that we are having such a nice discussion on every Wednesday, first Wednesday when we do this every month. And I think we discuss many things and we all learn many things and go. That is also there. And we had an excellent journal club discussion. The two residents did a very nice job, and Dr. Bashir moderated it very well. And quiz was definitely very, very interesting. A lot of learning points and a lot of take home points as well by Dr. Kaushik. And the other thing is that we are requesting you that if you have any journal club article to be sent which is concerning thyroid, any review article, any case report, case series, please send it to Thyroid Research and Practice, which is the official journal of the Indian Thyroid Society. The website is there. This is an online submission and it is a free publication. So you can just send your article. It will be peer reviewed and the decision will be taken on time. So if you have articles, please send it to the Thyroid Research and Practice because it is the official journal of the Indian Thyroid Society. And I hand it over to ma'am because ma'am is our mentor and she has always been there guiding us for this.
Thank you so much, Pramila. Kaushik, which was the question that you had from the from our journal, the ITS journal, TR, Thyroid Research and Practice?
You are muted, Dr. Kaushik.
I'm just curious to know. You did have one question, I'm sure.
Yes, I have taken one, but I just
no, that's okay. That's okay.
I don't remember
so, like,
right now.
Yeah,
but I have taken one.
No, that's fine. So I think that's what we are trying to highlight. And Pramila's already mentioned that we need to have publications to be, otherwise we don't get indexed. Anyway, we're still trying. I think we've missed Dr. Goswami today. I think he informed Bashir, I think. Dr. Bashir?
Yes, ma'am. Yeah. Yes, ma'am.
So you've had a double role to play today of chairperson and moderator. And of course, I need to really thank you because I think I called you maybe because we were planning to have Aligarh. But then I came to know that Hamid said that they don't have DM students as yet. I mean, they have a department, but they haven't started the DM program. Yes. So then thank you. It's very kind of you to have accepted.
Thank you, ma'am.
Really. So congratulations to both Sailesh and Azaz for both the nice presentations. Unfortunately, I'm not sure, Doctor, there's something wrong with Dr. Prasanna's audio. It was not very clear.
Yeah. Yes. Normally it is very clear. Today it was like not at all clear. Something was wrong.
But even he's passionate about radioactive iodine and I'm equally passionate about it. So I'm sure he was trying to give that message that the first treatment of choice should be, because the journal club was on long-term outcomes of anti-thyroid drug treatment. So I'm sure he was trying to talk about that as well. And of course, the second journal was again very interesting and he highlighted the strengths and the limitations. And Kaushik, thank you for that very, very nice quiz as well. So I think Ganvi will be showing us what's coming up next. So we need to thank Pramila, of course, for being with us again very regularly. I'm not sure if Arun and Mini have been able to join us. And of course, our excellent coordinator, Ganvi, who's again always with us. Thank you to the digital team. Mansi is there. And I think, I'm not sure if Vidhi is there. Aman, I thought I saw Aman's name along with us. So thank you all, especially Dr. Bashir and the entire team that's with us today. We just need to know what's happening in the next one. That is in December. So the dates are varying because of, there are subtle reasons. We had to change the date because of the Endocrine Society conference, which is also around just before this. So I thought we'll just keep it a little later. Yeah, Ganvi, please go ahead.
Yes, ma'am. So the next session will be on 20th of December, where we have Dr. Preeti Dabadgaon ma'am as the chairperson. To moderate the session, we have Dr. Sinha. And there'll be two case presentations, one on congenital hypothyroidism and the other on Graves' disease, again in children. So in between, we shall have a quiz by Dr. Neeraj Sinha. So I request each one of you who has joined today to join for the upcoming thyroid clinics as well.
That will bring us to the close of the year, right?
Yes, ma'am. Yeah.
2000, we'll be welcoming 2024 in a couple of days after that. Yeah, so all these, I think Nikhil Sanjeev wants to ask for the link. So please, all the meetings that we've had, starting from April 2022, are all available on YouTube. Right? So, Mansi?
Hello.
Yeah, Mansi, can you share that link in the chat box?
Ma'am, all the sessions are available on ITS website and YouTube also.
Yeah, can you just mention it? Because
Yes.
somebody's asked, like what is the
I'll
website?
drop the link.
Yeah, please just send them the link. That will be very nice. And if you do it right now, they can sort of note it or access it as well. So they're all available, each and every one of them. So those of you who have missed anything, recently I was in a conference, and I mean, even one person tells me yes, that they enjoy attending the sessions and they're encouraging their residents. I think that's rewarding enough. That's rewarding enough. But thank you everyone for joining us and being with us. Thank you, Asmita. There, you've already shared that. So that is the link for the website. And of course, we're always encouraging everybody to become members as well. Of course, and a happy Diwali in advance. It's just a couple of days. Yeah. So good night. Thank you.
Thank you. Thank you, ma'am. Yeah. Good night.
Good night, everyone.